Perfect. All right. Good afternoon, everyone. My name is Lisa Lee. I'm with the LA County Medical Association. I'm the VP of Operations and Strategic Initiatives, and I wanted to thank you all for joining us today. We have a very special speaker, Anastasia Dodson, who will be talking to you all to talk about, how to educate your patients on the upcoming changes regarding Medicare and Medi-Cal. With that, I'm going to introduce our speaker, Anastasia Dodson, who currently serves as Deputy Director for the Office of Medicare Innovation and Integration at the California Department of Healthcare Services. She provides focused leadership and expertise on innovative models and strategies for Medicare beneficiaries in California, including both dual eligible and Medicare only beneficiaries. Anastasia has been part of the DHCS leadership since 2013. She previously served at the California Department of Finance, the County Welfare Directors Association of California, and the California State Senate Budget Committee. She earned a Master of Public Policy degree at the UC Berkeley Goldman School of Public Policy and a bachelor's degree in economics at the University of Pennsylvania. So with that, I will hand it over to Anastasia. Thank you.
Thanks so much, Lisa, and it's really a pleasure to talk to you all today. We do have a lot of things going on for January around people who are dually eligible for Medicare and Medi-Cal. And at the State Department of Healthcare Services, we are the state's Medi-Cal agency, but really it's a partnership across so many of you, the facilities and organizations that you work in, as well as our county partners, patients. It's a whole ecosystem, as you know, to serve people in California, people with Medicare, Medicare, and Medi-Cal. So this presentation today is going to, as I said, focus on some changes that are coming up for January 2023, but they're sort of ongoing programs. So good for you to know what your patients may be coming in and have questions about, but then even going forward in 23 and 24, you may find this information valuable because these are ongoing program changes. Next slide. So we're going to do a quick overview of people who are dually eligible for Medicare and Medi-Cal, talk about some of the key transitions and the options that folks have on the Medicare side, some key reminders and resources, and then hopefully lots of time for questions. Next slide. So first an overview, next slide. So people who have both Medicare and Medi-Cal, sometimes they're called Medi-Medis. Those are folks who qualify for Medicare, either they're over 65 or under age 65 and have a disability. And Medi-Cal is a program for low-income Californians. So Medi-Medis are folks that are either over 65 or under 65 with a disability and who are low income. Unfortunately, but maybe not surprising, the folks who are dually eligible are more likely than people with Medicare only to report being in poor health. This is a national figure, but it holds true in California as well. And then just for context, so of the 6.6 million or so folks in California that have Medicare, about 1.5 million have also have Medi-Cal. It's again, only a portion of those people who have Medicare, but that it's not an insignificant number. 1.5 million folks who have Medicare and Medi-Cal. And those of the 1.5 million, 43%, this is as of 2021, have Medicare Advantage, and 57% have original or fee-for-service Medicare. So some of you may have patients in original Medicare, some in Medicare Advantage plans, but as you know, Medicare Advantage enrollment is growing every year quite a bit. Some of what we will be talking about today are a type of Medicare Advantage plans for people who are dually eligible. Next slide. So as you know, Medicare and Medi-Cal, they they cover two different sets of populations, and then for people who have both, there's a defined way that the two coverage programs overlap. So for people who have both Medicare and Medi-Cal, Medicare covers doctor visits, hospital stays, labs, prescription drugs, and other benefits. And then Medi-Cal covers their Part B premiums and co-pays, and then long-term services and support. So adult day health, skilled nursing facility care. Medi-Cal actually covers dental, although I know many Medicare Advantage plans also offer dental, but Medi-Cal covers dental. And then in-home supportive services, which is a program that allows people who can live safely at home to hire caregivers to help them stay at home, help with activities of daily living. So IHSS, nursing home care, adult day health care, those are all covered by Medi-Cal for people who have Medicare and Medi-Cal. And then one more piece of information for you to have. Most people in California who have Medi-Cal are enrolled in a Medi-Cal Managed Care plan. And that is a little, it's important to know, but again, part of the landscape here that sometimes is difficult for patients to navigate is on the Medicare side, they can be in original Medicare or a Medicare Advantage plan. And on the Medi-Cal side, most people with Medi-Cal are already enrolled in a Medi-Cal plan. And one of the changes we're going to talk about is that starting in January, even more people with Medi-Cal will need to be enrolled in a Medi-Cal plan. But again, Medicare, that's voluntary for a Medicare Advantage plan, but Medi-Cal, it's going to be mandatory to choose a Medi-Cal Managed Care plan. Next slide. So again, already you can see it's a complex topic between Medicare and Medi-Cal. The two programs, they are separate. They have different funding streams, and they can be quite fragmented for people. And then again, thinking about dual eligible beneficiaries with chronic conditions, functional impairments, it can be very confusing and hard to navigate. And particularly, if they need long-term services and supports, they get that from Medi-Cal, but their hospitalization and doctor visits are Medicare. So some of what we'll talk about today is ways that we can, options for coordinated care for people who are dually eligible. Next slide. So we'll then dive into some of the enrollment changes here. Next slide. Okay, so first we'll talk about, we're calling them Medi-Medi Plans. And these are formerly Cal MediConnect plans. And all of you in Los Angeles County may be familiar with these types of plans for people who are dually eligible. Next slide. So Cal MediConnect is a program that's been in place since 2014. It's a demonstration, a certain special type of a health plan that combines Medicare and Medi-Cal together in one health plan. The Cal MediConnect plans are available through the end of this year in the 7 counties you can see on the screen here, including Los Angeles. On January 1st, folks who are members of Cal MediConnect plans are going to be automatically transitioned into what we're calling Medi-Medi Plans, run by the same organization. So whether it's Anthem or HealthNet, LA Care, Molina, those same organizations, they currently have Cal MediConnect plans, and they will be creating, establishing, and then moving their members into the Medi-Medi plans. And it should have the same providers, the same benefits, same type of care coordination. And we can talk a little bit more about what the differences are, but in essence, it should not be disruptive at all to members, and it should not be disruptive to physicians and clinicians. And these new Medi-Medi plans, one thing I want to emphasize, it's not just that the Cal MediConnect members are transitioning, it's that the Medi-Medi plans are open for new enrollment, and it's Medicare open enrollment period right now. So anybody who is in those 7 counties and who is dually eligible, they can choose to enroll in the Medi-Medi plan for both sets of benefits. Next slide. So a little bit more about these types of plans, Medi-Medi plans. They are technically a type of D-SNP. You may have heard of that, which is, it's a type of Medicare Advantage plan specifically for people who are dually eligible. And in this case, it's not just the D-SNP, which is, again, a Medicare Advantage plan for duals, but there's the companion piece of the Medi-Cal plan, and they are working together in the same organization, the same plan. And in fact, from a member or beneficiary perspective, they appear as a single plan with one card, one welcome packet, one phone number for member services and care coordination. And again, the specific contract requirements of these Medi-Medi plans is they are required to coordinate care across all of a member's Medicare and Medi-Cal benefits. That's the federal requirement and the state requirement for these types of plans. Next slide. So you can see, I mean, you're all very familiar with all the variety of benefits and services that people need. And again, dual eligible beneficiaries, they tend to have more chronic conditions. And so they may need to access, a variety of services. So the Medi-Medi plan, the idea is that they should be coordinating all of those services, even though, for example, specialty mental health in Medi-Cal is provided actually by the county or through the county rather than the Medi-Cal plan. But nonetheless, the Medi-Medi plan should be coordinating with the county for specialty mental health, people with, need those types of services. Nursing facilities, nursing homes, those are all contracted with Medi-Cal plans, so they should coordinate with nursing homes. And then on the Medicare side, if again, a Medi-Medi plan is a type of Medicare Advantage plan, so they have physicians, hospitals, labs, et cetera, all in their network that they should work across both the Medicare and the Medi-Cal together. Next slide. So one thing for you all I really want to emphasize is that the federal government and the state, we are both closely monitoring this transition from Cal MediConnect to the Medi-Medi plans. And the Medi-Medi plans, those same Medicare Advantage organizations, they have network requirements. They already had them in Cal MediConnect. And then with this transition, another federal review of their networks to make sure that they have an adequate network of physicians, hospitals, et cetera. And then there's a continuity of care period. So if a physician, either primary care or specialist, is treating a patient who's in a Cal MediConnect plan, and then there's this transition to the Medi-Medi plans, and for some reason that that physician, specialist, et cetera, is not in the sort of renamed network, then the patient can continue seeing that provider through the continuity of care provisions. We're requiring the plans to provide an opportunity to providers to continue seeing those patients and get paid. And they basically get paid sort of whatever the normal rate is with that the plan is paying its providers. So, you all are the experts on, how that would work out with the health plans. We've set certain criteria there. But happy to answer more questions or hear of any experience you may have had on that. But we're trying our best to make sure that there is no patient disruption with this transition. Next slide. So now we're going to look at a different transition, and it just happens that many of these are all happening January 1st. So that's why we're kind of bundling them together. Next slide. So D-SNP lookalike plans, you may have heard of these. These are a type of Medicare Advantage plans that are marketed to people who are dually eligible for Medicare and Medi-Cal, but they're actually just regular MA Medicare Advantage plans, and just happen to get 80% or more of their members are eligible for Medi-Cal. So it's not a coincidence that they have such high enrollment among duals. In the past, these types of plans have been set up and marketed specifically to dual eligible beneficiaries. But those D-SNP lookalike plans, they don't have the same integrated care requirements as true D-SNPs, and they don't have the type of care coordination requirements for duals. So the federal government, CMS, we can go to the next slide, is then limiting enrollment into these types of plans So last year, they did not enter into any new contracts for these types of plans. And then for 2023, they're discontinuing these contracts. However, we all want to make sure that members of these plans have a smooth transition. So we'll go to the next slide. CMS, the federal government, has been working with the MA plans that have these types of D-SNP lookalikes, and they worked very carefully to have transitions into, so as you probably know, Medicare Advantage plans, they offer many different products or lineups as far as Medicare Advantage plans or D-SNPs. And so the folks who were in these D-SNP lookalike plans, there's a seamless transition into another product offered by the same plan. And so basically, most often a Medicare Advantage organization, if they have a provider network in a particular plan, they probably have very similar, if not the same provider network in some of their other plans. It's not the same for across all the plans all the time, but for this transition, CMS, the federal government, is looking to make sure that folks who are transitioned here are going to get continuity of care. They're going to stay within the same plan organization. So it should not be too sort of confusing for members. So that is the crosswalk solution that the federal government came up with. And in fact, that crosswalk, those enrollment transitions have already been made. They made them in, I think, last week. And so somebody who was in, program plan XYZ, they are going to be in a different plan, but still within that plan organization. And they did get notices of this at the end of September. Next slide. So a couple more pieces of things that are happening January 1st. This is about Medi-Cal. What we just talked about, the Medi-Medi plans and the D-SNP lookalikes, that's all about Medicare. This part is only about Medi-Cal. Next slide. So in California, the counties that are in kind of the purple along Northern California, along the coast, everyone who is in Medi-Cal is already enrolled in those counties in a Medi-Cal Managed Care Plan. They may or may not be in a Medicare plan, but on the Medi-Cal side, they're in a Medi-Cal plan. In the pink colored counties, which includes Los Angeles, most people who are dually eligible are enrolled in a Medi-Cal Managed Care Plan. There are some people who are not. They should have been in previous years, but we've been doing some corrections in our data files. So some people in Los Angeles County who are dually eligible got a notice that says you will need to choose a Medi-Cal Managed Care Plan. And I want to talk to you a little bit more about what that means. The other color on this map is kind of a bluish color in sort of Central Valley counties, Sacramento area, parts of the Bay Area, and Imperial County. Many more people who are dually eligible are not already enrolled in a Medi-Cal plan in those counties. And so it's actually a larger percentage of people in those counties that are getting these notices. But I want to flag that there are some people, and I think it may be even 40,000 or so in Los Angeles County, who are getting these notices. Next slide. So what does it mean for people who are Medicare and Medi-Cal duals to be in a Medi-Cal plan? The main point, I think, just at the bottom here in bold, I want to emphasize, being in a Medi-Cal Managed Care Plan does not in any way impact someone's access to Medicare providers. And it doesn't change their choice of being in Original Medicare or Medicare Advantage. Also, Medicare providers do not need to be in the Medi-Cal plan network. So this is a complex area. Some providers think, they might tell their patients, only choose a plan where I'm in the network. Well, that doesn't need to be the case for Medi-Cal. If you are not in a Medi-Cal network and you have patients who are dually eligible and they come to you and say, I need to choose a Medi-Cal plan, can you help me? You can just tell them, whichever Medi-Cal plan you choose, you know, I'm still your doctor. You can still see me if you're already that patient, and they, you know, whatever they're doing on the Medicare side is really what matters. If they're in an MA plan or if they're in original Medicare, if you're seeing them, the Medi-Cal plan doesn't change that relationship, and it doesn't. We can talk if you like more about, you know, payment structures, et cetera. It won't change the sort of secondary billing or anything like that. So we will keep going, and then we can come back to this part if folks have questions. Next slide. And just for context, over 1.1 million people who are dually eligible are already enrolled in a Medi-Cal Managed Care plan. And then this lists the counties. It doesn't have LA here because, again, most of the folks, dually eligible folks in LA are already in a Medi-Cal plan. But again, the folks who are choosing a Medi-Cal plan for the first time, they'll get materials, and then they can, they'll have a choice packet that they're going to get. Next slide. And why are we doing this? Because Medi-Cal plans, they provide, they have contracts with skilled nursing facilities and other types of long-term services and supports. And in particular, something we rolled out in 2022, it's called CalAIM Community Supports, that offers things that are would be probably beneficial to people who are dually eligible. Home modifications, medically tailored meals, also care coordination if people need help trying to get into an assisted living facility, other types of care coordination to help them navigate if they need higher levels of care. Next slide. This one I'm not going to get into. It's a little bit technical, but again, if someone is in a Medicare plan that also is contracted as a Medi-Cal plan, then whenever they make that choice, if they make a choice about being in a Medicare plan, we will automatically enroll them into the matching Medi-Cal plan. So they're not in a mismatch if possible. Not every Medicare plan has a Medi-Cal plan, but if they do, then we want people to be in with the same organization. It's not exactly the same as what we talked about, the Medi-Medi plan, which is like a really more integrated approach. But you know, just for you to know, that's one of the sort of automatic Medi-Cal rules that we have. And again, we don't ever interfere with people's Medicare choices. They make their Medicare choice, original Medicare, Medicare Advantage, and then we just do things automatically on the back end about Medi-Cal. Next slide. So we'll just briefly talk about the notices, and then we can go to questions. Next slide. This is an overview of notices. So we've already sent notices around the Cal MediConnect transition and the D-SNP lookalike. We've also sent the first set of notices around enrolling in a Medi-Cal plan. And then in December, there'll be additional notices that go out. And actually, it's by December 1st. So in the coming weeks, there'll be more notices about needing to choose a Medi-Cal managed care plan for those folks who are not in a Medi-Cal plan. Next slide. Okay, keep going. Next slide. So this just talks about the options that people have in a county like Los Angeles. So the first one is original Medicare. Yes, always an option, and which is Medicare fee-for-service, regular Medicare. They're not in a Medicare Advantage plan. And then they can choose any Medi-Cal plan that's available in Los Angeles if they are in original Medicare. Then there's the Medi-Medi plans we talked about that are one plan combined across both sets of benefits, Medicare and Medi-Cal. And then there's other Medicare Advantage plans that they don't need to be a D-SNP, don't need to be a Medi-Medi plan, just regular Medicare Advantage. There are lots of those plans available. And then again, that matching plan policy, if there's an affiliated Medi-Cal plan, we automatically enroll them. And then in certain zip codes, there are PACE programs where, and we won't talk in too much detail about PACE, but those are for folks who meet the nursing facility level of care need. And there's also SCAN. I know SCAN is a Medicare Advantage and D-SNP anyway, but they have a particular plan that also similar to PACE for people who have high levels of need nursing home level of care. that scan plan can combine across Medicare and Medi-Cal for people who have that higher level of need. Next slide. So this gives you the names of the plans. You can see the PACE programs on the right, and then the scan, we call them a FIDE SNP on the right, and then the Medi-Medi plans on the left. And there are several choices, and all of these, again, are these. You'll be familiar with these names, these plan names, because they're the same as the Medi-Cal plans. And these are, again, combination of Medicare and Medi-Cal combined together in one plan. And this is open to anyone who's dually eligible, and they don't have to have that higher level of need like in PACE or the scan FIDE SNP. And this is for Los Angeles County. Okay, next slide. And then just a few quick reminders, and then we can go to questions. Next slide. Balanced billing, you're probably familiar with this. So for the 20% cost sharing on Medicare, for people who are dually eligible, they should not receive a bill for that 20%. And we can certainly talk about, what's the process that should be followed for the co-insurance for Medicare beneficiaries, but the bill should not go to the beneficiary, the patient themselves. Balanced billing, it's prohibited. Next slide. The other changes I want to flag for you is starting in May of this year, Medi-Cal eligibility was expanded for people who are low income, but had not previously been able to enroll in full scope Medi-Cal because of immigration status. Now we have a full eligibility, full scope Medi-Cal eligibility for folks who, regardless of immigration status. So that was a big change that we made in May, and anybody that we had in our systems that had sought emergency care, and that was covered by Medi-Cal, we've actually converted those folks, and they now have full scope Medi-Cal. But people who are not already enrolled in Medi-Cal for any reason, they can enroll as long as they're low income and age 50 and older. And so that's a big change. We're really pleased. And again, that helps the whole community so that everyone has care. The other change is the Medi-Cal Asset Limit Increase. So starting in July, the Medi-Cal Asset Limit increased from $2,000 to $130,000. So that's really for things like checking account, savings account, other types of assets. Someone's primary residence, that's already exempt, but for people that had some kind of savings accounts, as long as they are low income, the Medi-Cal income limits still apply. As long as they're low income, they can have an increased amount of assets and still be eligible for Medi-Cal, which again is really helpful for people, so they don't have to spend all the way down to $2,000 for one person, and they can get help, and especially with their Part B premiums and the co-pays. Many times that's what is, of course, long-term services and supports, that's good too, but getting help with those Part B premiums can be really valuable to people. Next slide. So I think we can go quickly to the next slide. So we have a lot of materials, fact sheets, etc. on our website. And next slide. Hey, so good. We have lots of time for questions.
Fantastic. Thank you so much, Anastasia. We did have a couple of questions come in through the chat. So the first is from Mark Siegel. What happens to someone with a disability who has straight Medicare, a PPO Medicare supplemental policy, and straight Medi-Cal?
Good question. People who have Medi-Cal, they don't need to have a Medigap policy, which I think that's probably the Medicare supplemental policy, because they should not have any co-insurance or co-payments or Part B premiums if they have Medi-Cal. Sometimes people, maybe they had that policy before they enrolled in Medi-Cal, and then but they can drop that policy. They don't need to have any kind of Medigap if they have Medi-Cal.
Great, thank you. The next couple of questions that came in through the chat are about crossover claims. So the first one is, how do you handle the deductible and the 20% if they are in a Medi-Cal plan?
Yes, great question. And again, this is how it already works in Los Angeles for people who are already enrolled in Medi-Cal Managed Care. So if sometimes when people who are in original Medicare, the claim is submitted to sort of the clearinghouse on the Medicare side, and then they on the back end, if all the computer systems are working the way they should, then the Medicare contractor has the Medi-Cal plan information. They automatically send that claim, the 20%, over to the Medi-Cal plan, and then they process it. And they, oftentimes I'll just say sometimes, probably often, it will be a $0 payment, but at least the claim will be adjudicated, and then your office will get back that claim adjudication. And for your accounting purposes, tax purposes, you can say, okay, this, I don't know if you call it bad debt or however that may be, appropriate for you to record it in your business. If that automatic process is not working right, also the claims can be submitted directly to the Medi-Cal plans for the 20%, and then they should adjudicate those claims. Again, sometimes they will pay some amount on those claims, the 20%. It just depends on what is the Medi-Cal reimbursement rate. Often, if the Medi-Cal reimbursement rate is the same as 80% of the Medicare rate, then there will be no additional payment. But if the Medi-Cal rate is any higher than 80% of the Medicare rate, then the Medi-Cal plan would be responsible for paying whatever that incremental difference is. Again, in theory, the claim submission, you shouldn't have to submit that second claim to the Medi-Cal plan, but we know that there are probably glitches in the system, and so you may end up needing to submit that claim directly to the Medi-Cal plan. Right now, for folks who are in fee-for-service Medi-Cal, those secondary claims can be submitted to the State Department of Healthcare Services, and that's where the transition comes in, where the secondary, instead of being billed to the State Department of Healthcare Services, it goes to the Medi-Cal plan. And you may not know which Medi-Cal plan your member is in if you're really focused on the Medicare side of things. And that's where we are hopeful to make sure that the back-end systems are all programmed correctly so that it goes automatically to the appropriate Medi-Cal plan.
Great, thank you so much, Anastasia. And I believe that actually answered the follow-up question, which was, how do doctors get paid for the deductible if someone is in a Medi-Cal plan and the Medicare doctor is not part of that plan?
Right, kind of the same idea. And I just, I don't want to tell you anything that's not true. So it may be that you will not get any additional payment beyond the 80% that Medicare covers. It just depends on the procedure code, but in many cases it's $0. But again, there may be some, benefit as far as your accounting, tax, how those are recorded, those $0 claims, and depending on if you're, independent practitioner, if you're part of a hospital or other organization, sometimes there's bad debt that Medicare makes payments back to hospitals for that.
Great. And then Anastasia, there was a comment in the chat about how many physicians will refuse to bill Medi-Cal. And so I wanted to see if you had any comments or commentary that you wanted to add to that.
Yeah, I mean, I don't want to tell you how to run your business. It may be that if you are not going to get anything beyond what Medicare pays for that patient, you don't necessarily need to bill the Medi-Cal plan or the State Department of Healthcare Services for that 20%. So that's really a longstanding policy. It's really a national policy, I'll just say, because in a number of other states, the Medi-Cal or the Medicaid rates are oftentimes equivalent to 80% of Medicare. And that's, unfortunately, it's not unique to California. It's in other states as well. But in some, again, depending on how good the budget is and, what the particular procedure code is, in some cases, Medi-Cal will pay more than the 80% of Medicare. And in that case, you would be, if this is for a dual eligible beneficiary, you'd be entitled to get that difference.
Great, thanks so much, Anastasia. And I see that we have a hand raised. Willie Goffney, would you like to come off mute and ask a question?
Oh, a comment. Thank you for presenting to us today, Ms. Doctor. In the old days, when Medicare approved an amount, physicians were able to bill Medi-Cal that 20%. Then Medicare did not pay. 5 or 6 years ago, it seems to me, Medi-Cal just stopped paying the 20% without asking physicians what they thought about it. I don't know how that came about, but the effect to us is essentially that we've taken a 20% pay cut. It's not publicized anywhere, but we've taken a 20% pay cut, and that's a big deal. And so if you have any data that would explain how that came about, I would love to see it. Second comment I have, and actually it's a question, what are we physicians supposed to do when an IPA or an HMO refuses to pay on a Medicare Advantage patient? And to be specific, I had a patient recently who had been in a skilled nurse in a long-term acute care facility for 3 years. Was seen by me frequently, at least every 2 days or every 3 days. And after that 3-year stay, the patient was too sick to go home to go to a SNF or to go home. Finally, they did get him home, and he died the next week. So he required a lot of care. The IPA just recently told me that they weren't going to pay for my services, at least not the balance of what they owed. They had paid intermittently, like 1 month they might pay, the next month not pay, and so forth and so on for the whole 3 years. So who do I complain to? How do I address this issue? Do I have to go to court?
Thank you. Okay, so on the first question around changes in the Medi-Cal policy for the 20%, I will go back and ask our experts here, the third-party liability folks. I'm not aware of any particular policy change. I mean, there may have been some systems update, but unfortunately, it's been kind of longstanding that Medi-Cal rates are lower than 100% of Medicare, and so definitely sort of beyond my pay grade to have any solution for that necessarily. It's a sort of much larger issue, but I will go back and check to see if there was some technical adjustment 5 or 6 years ago that sort of changed what was happening, and I'll ask some of our experts. And then on your other question about like an IPA or an HMO, I think what we should do is also get back to you on that. I'm not familiar with the appeals process between physicians and IPAs or HMOs, but I imagine there is a process. So, Cassidy will take your information and we'll find out about that. So sorry, I'm not giving you a satisfactory answer on those.
Well, I would love to have it. And I can tell you, I've been in practice now for 32 years. And for about the first 18 to 20 years, we could collect on that 20% that Medicare did not pay. That was straightforward. That all changed. And all of the different Medi-Cal plans have sort of adopted the same practice of not paying. They set the Medi-Cal rate low enough that whatever Medicare has paid is going to be higher than what the secondary insurer thinks that they ought to pay. So they're really not behaving as secondary insurers. They are behaving as if they were the primary payer. And they say, well, you've already been paid more than we would have paid us if we were the primary payer. For us, they should be a secondary payer. And Yeah, I feel like we are owed the 20% that Medicare has approved. Short of that, we've taken a 20% pay cut. Across the society, if you take a 20% pay cut, most providers would be up in arms.
Yeah, I will check with, and you said it was 5 or 6 years ago.
About 5 or 6 years ago is when the practice started. It has been globalized so that any insurer that previously would have been considered a secondary payer has stopped paying, and they send you a notice essentially saying that, well, Medicare already paid you more than we would have paid, and so we're not paying anything.
Right. Yeah, I mean, unfortunately, my understanding is it's been longstanding about basically Medi-Cal won't pay anything over the Medi-Cal rate. And if the Medicare rate is the same as or if 80% of Medicare is the same as 100% of Medi-Cal, then Medi-Cal will not pay anymore. But I am curious to know why things changed, like you say, 5 or 6 years ago. And there are some, I mean, it also could have been that in the with the launch of the Affordable Care Act, there was a temporary bump in primary care rates that also applied to Medi-Cal. And so maybe there, but like you say, if it's been 18 years or so, that's been, you've been paid. Well, yeah, and we'll talk to the Medi-Cal plans in Los Angeles. We'll talk to LA Care and HealthNet and Molina and find out if they've done something different.
I'd love to hear directly back from you about this issue and about what providers are supposed to do when the health plan that Medicare Advantage has contracted with refuses to pay a claim.
Mm-hmm. Yeah, that'll be a different person I'll talk to and find out from.
Okay.
Thank you.
Reach out to me through email. I'd love to hear back.
Right, and Cassidy, you have that. No. Okay, great.
Yeah, from the registration list. So we'll reach back out, Willie. Thank you so much. And then Anastasia, there was a clarifying question actually about this conversation from Stephanie Booth in the chat. Could you please clarify when a doctor can get the 20% that Medicare doesn't pay? Right. So if, and you know, I don't know which procedure codes, but if there's a procedure code that 100% of Medicare is $100 and 100% of Medi-Cal is $95, then that difference between 80, which is the 80% of Medicare, and 95, which is the upper limit of Medi-Cal, that $15 then is what the Medi-Cal plan should pay to the provider. And so, and I see Dr. Goffney saying no, but in theory, you know, if the Medi-Cal rate is set above 80% of the Medicare rate, then the Medi-Cal plan is required to pay that difference if they get the claim. So, but again, I don't have a list handy of all, what are the sort of major procedure codes where the Medi-Cal rate is set above 80% of Medicare. And it may be more for certain kind of specialized services. I think maybe, I don't know about ambulance transport. There's some areas where, frankly, I think you all have, advocated to have like the Prop 56 payments for Medi-Cal that increased the Medi-Cal rates. And so however, those sort of Prop 56 payments and other types of special funding have been targeted to certain procedure codes. Those are the ones that Medi-Cal should pay above the 80% of Medicare. Great. And then one more clarifying question from the chat. Would the 20% Medi-Cal payment be dependent on if a physician is enrolled in a specific Medi-Cal plan? What happens to the patient with straight Medicare and a managed Medi-Cal plan in these situations? So there should be no difference. The Medicare physician is not supposed to need to be enrolled in the Medi-Cal plan in order to get that difference. If they're, again, in that example, if there's, Medi-Cal pays $15 above the 80% of Medicare, and this is where, we're reinforcing with the Medi-Cal plans that providers do not have to be enrolled in Medi-Cal in order to get that difference. They should be making that payment to any Medicare provider, regardless of whether they're in their network. Fantastic. And then a question in the chat from Juan Silva, and this might be one we need to take back, but are private practices eligible for ECM enhanced rates?
Good question. Yes, so ECM, Enhanced Care Management, is on the Medi-Cal side for people with, complex conditions, maybe high utilizers, substance use disorder services, et cetera. Medi-Cal Managed Care Plans contract with, a variety of organizations for that enhanced care management. And so as far as I know, like you say, Cassie, you might have to take it back, but there's a wide variety of providers and provider types that are eligible to be ECM providers and to contract with the Medi-Cal plans. But you have to be in the Medi-Cal plans network to be getting paid for enhanced care management. Again, that's a Medi-Cal managed care benefit that we rolled out to some degree in 2022, and we're expanding in 2023.
Great. And then another question in the chat from Stephanie Booth. Does this mean the insurers get to keep more money when they are insuring patients through Medicare and Medi-Cal?
That's a good question. Not really. So when a Medicare Advantage plan, they get a capitation payment from the federal government for all of the Medicare services that are Part A and Part B, and then if Part D is included. When a Medi-Medi plan, they get still that payment from Medicare for the Medicare services, and then they get a payment from DHCS for the Medi-Cal pieces. And our actuaries set the rates that get paid to the plans. And in theory, the actuaries set the rates where, on average, across many patients, their services, their costs will be sort of very close to that capitation rate. And if the plans are appropriately managing, either through you all, maybe there's a strategy that they use with physicians for some kind of pay for performance program, people will not progress to the point of needing a skilled nursing facility, or if they do, it's for a short stay, not a long stay. They can get back to the community. Their diabetes, hypertension, et cetera, is managed to avoid hospitalizations. So Medicare and Medi-Cal plans, they have incentives to, have contracts with you all so that you're, of course, this is the fundamental work that you're doing is helping manage patients' conditions and avoiding the, more expensive and more sort of complex situations. And of course, some of them, there's only so much can be done. But anyway, the payments that the Medicare and Medi-Cal plans get are designed to give them the incentive to give you all the incentive to, manage people's care as, best fits patients' needs and abilities.
Thanks so much, Anastasia. And then we have a raised hand from Alvia Valen. If you'd like to come off mute and ask your question.
Yes, hi, I'm with Silmar Medical Center, and we have a question. We have some patients that have Medicare Part B only, so they don't have A. And when they don't have A and B, they can't go into an MA plan. So they have Part B, and now their Medi-Cal has to be assigned to a managed care. It's required to be assigned to a managed care. How do we get paid? Forget about the 20%. We'll exclude that. How do we get paid for the deductible? Because the first, few visits are towards the deductible, and we're getting zero from everywhere. How does that work when the doctor is not in the managed care plan and the patient only has Part B?
That's another good question and a good scenario. So in that situation, the Medi-Cal plan, it will work better for the patient if they if you are enrolled into the Medi-Cal plan, because the Medi-Cal plan is responsible for I guess we'll just call it the Part A, the hospitalization. If they are, if the Part B is through Medicare and you all are the Medicare providers, but you're not in the network, I don't think that we have a good solution for that. As far as, again, most of the slides here, we're talking about duals, people with both Part A and Part B. For people who are partial and they're in a Medi-Cal plan, I'll take that back though. I'll just triple check, but I don't think the Medi-Cal plans have to pay in that situation. But I'll find out. And
Because
Cassie,
the reason we can't go into a managed care from the area. What happens is when we opened our managed care for Medi-Cal, we can't help anybody. We get bombarded by thousands of patients. So we end up, it's not feasible to even take care of our patients that we have. And now we have a lot of patients that have B only in the area in Sylmar. And it's a poor area and we can't help them either because they have to be in a managed care plan for their Medi-Cal. It really puts, and the specialists don't take them. We're having a really hard time with this scenario, and we're having a hard time helping patients with this scenario.
Yeah,
so if you guys can do something for that group of patients, that would be great. We have one patient that has a brain tumor that we can't even get anyone to even operate on them, and we're struggling. So
okay, so one thing that we can do. Right. One thing that we can do then is, people sometimes, if they are low income and they're not enrolled in Part A, there is a process that the county eligibility office and the local Social Security Administration office, if they can work together, they can help people get into the Part A. We also have ombuds program that for dual eligible folks that they might, like if you're finding that you have even just for individual patients, but then especially a group of people, then yeah, Cassidy will take your information and then we will work with advocates and county eligibility office, because there may be a way we can, do a little webinar or somebody who's actually local near you can come and visit and talk about a process to help people get, because yeah, ideally they would get their Part A. That would solve everything.
Yeah, we're happy to take that back and follow up. Thank you so much.
thank you.
All right. I think that we might have time for maybe one or two more questions. I'm not seeing any new ones in the chat. Anybody else would like to come off mute? Please feel free to raise your hand and we'll call on you. Stephanie Booth, I see you've raised your hand.
Yeah,
Please
hi
feel
there.
free. Yeah, go for it.
Thanks for all the good information. I'm just wondering if there's, in the worst case scenario, physicians will quit in droves. And I'm not so sure that's impossible. I'm wondering if there's a plan of what to do when that, if and when that happens. Is there a way to quickly increase rates or something?
Yeah, I hear what you're saying. We've had on the Medi-Cal side, at least, because that's what we at DHCS can control. We have had various kind of targeted rate increases. And I do see the chat about, concern that if we, send the rate increases to the Medi-Cal plans, are they truly passing them on to physicians and providers that they're contracted with? We do audits, we do reviews, but I will flag to, because I'm not familiar with exactly how those audits work, but we absolutely, we want to keep all of you, as long as you can, helping patients, being part of this, important safety net and healthcare delivery system. You know, the examples that you're bringing up, I mean, you are saving people's lives, of course. You're helping them, you know, maintain being able to live at home, you know, keep functioning and enjoying life. And so we, you know, we can't change the Medicare rates at DHCS, but you know, through the state legislature and you know, other initiatives, the California Medical Association, you all work on, you know, that can help us increase rates on the Medi-Cal side. But we don't, the Medicare rates at the state level, we aren't, we don't have that influence.
Well, thank you. I sure appreciate your honesty.
Yeah, thank you.
Thanks, Stephanie. And I see that there's a final comment in the chat from Mark Siegel. The worst case scenario for patients is for physicians to refuse to accept new Medi-Medi patients. Any last questions or comments from anybody? If not, I'll go for it, Anastasia.
Yeah, it's you really good questions and good scenarios for us to look at. And I think, you know, sounds like if there's an opportunity in the future, I appreciate your listening about these, you know, transitions, but that sounds like we should keep in touch in the new year and not only respond back to you individually, but, you know, think about some kind of a future conversation if possible.
Sounds great. Well, thank you all so much for taking the time out of your very busy schedules to come join us. We really appreciate the great discussion, and as Anastasia said, the feedback, it's been very helpful. We've dropped a few links in the chat for folks. We'll take back those last questions and reach back out. And if you do have any other questions after the presentation, you can always reach out to the info@calduals.org inbox. That's also placed in the chat. And I think with that, thank you all so much. We hope you have a great rest of your day.
Where can we find the recording, by the way?
What was that, Willie?
Where can we find the recording of this section?
I believe that Lisa might have that answer.
Yes, Dr. Goffney, LACMA staff will be emailing the presentation out.
All right, very good. Thank you.
Thank you very much.
Great, thanks. Bye, everyone.
Bye, everyone.